So this is all about the treatment of lung cancer, first-line PD-L1 positive lung cancer. And there was a trial, the Keynote trial 045, that was published in October-November 2016, and that showed significant survival benefit of using this treatment in that setting. The dose that was used there was 200 milligrams, but there's some interesting history related to the dosing of pembrolizumab in other trials. Originally, when pembrolizumab was first brought into clinical practice, the original trials in melanoma several years ago were 2 milligram per kilogram. There were also some equivalency studies comparing 2 milligram per kilogram with 10 milligram per kilogram. There were some pharmacokinetic studies as well, and they showed that it was equivalent efficacy when using 2 milligram per kilogram versus 10 milligram per kilogram. Following that, the strategy of the company was to roll out fixed dosing for everybody, giving everybody 200 milligrams. So this lung cancer study that showed efficacy received FDA approval and became the standard of care for all metastatic lung cancer patients with 50% PD-L1 positivity, used a dose of 200 milligram fixed dosing, and that was the FDA approval. However, is this too much of a dose, and can we use a lower dose? So because the average lung cancer patient weighs approximately 75 kilograms, 150 milligrams would be an appropriate dose for such a patient, given that 2 milligram per kilogram is equivalent to 10 milligram per kilogram. So we did then a budget impact study analyzing the number of patients that would receive this therapy and comparing weight-based dosing of 2 milligram per kilogram with fixed dosing of 200 milligrams fixed dosing. And we found that this amounts to almost $1 billion annually. $0.8 billion is what our analysis demonstrated, is how much money could be saved in the United States if patients are prescribed weight-based dosing instead of fixed dosing.